talk now about access to health information. Who has access? How they get access? What are the laws about access to health information? Now, this, I think, has been pointed out several times that if you work in a healthcare organization or a provider of healthcare of any kind, you have to be aware that there are not only state laws, but there are federal laws that govern the confidentiality of medical records. We've been over HIPAA as far as the privacy rules of HIPAA, and you know about that federal law that governs the confidentiality of records. There's also other sources of rules and regulations in regard to confidentiality. Now, as I mentioned, we've been over the HIPAA privacy rules. We'll go over the HIPAA security rules of HIT 221. And both of those rules, which are just parts of HIPAA, have standards for confidentiality. In addition, there are state laws. And remember, if it's a state law, it will vary from state to state. But also there are additional federal laws other than HIPAA that govern confidentiality of some types of medical records or health information. Now, as far as the type of health information, I want to point out, not all health information is protected from unauthorized access. The privacy rule of HIPAA addresses patient identifiable information. So, information that can be linked to a particular individual. And that protected health information, the PHI, as referred to by HIPAA, is individually identifiable. But healthcare providers or covered entities can do something called de-identify health information. And de-identified information is that information for which the identifiers have been removed. There are certain things, in fact, there are 18 identifying data elements that are considered those things which could identify a particular individual in regard to health, the protected health information that can be removed, and therefore that information is classified as de-identified. So that if anybody saw particular health information, they would not know to whom that information pertained. So if health information is de-identified, it is then no longer covered under HIPAA as far as being protected. Now, ownership of the medical record. Now, the general rule is that the healthcare facility or the provider owns a record, but it's subject to the patient's interest in the information it contains. And what I've always heard and always said is that if the hospital owns the record, the patient owns the information in the record. And even though I can say that, for years and years in the state of Alabama, that was not true. Until HIPAA came along, in the state of Alabama, there was no law on the books to give a patient even access to his or her own medical records. Alabama law states that the health record is owned by the hospital, and under the control of the hospital's administration. But nowhere in the Alabama state law did it say anything, or does it, till this day, say anything about the patient's access to that information. And so what that did, if there was no law on the books to give patients the right to access medical record information or health information, it was up to each individual hospital to decide whether the patients could have access or not. Well, that changed, even though the law of the state of Alabama has not changed, because now we have HIPAA, which does give all patients throughout the country a right to access their medical records or their health information. So ownership is established by statute. So statute, remember, is a written law. And so in some states there is a statute that says the patient owns the information in their medical records, but in others there isn't. And where do you usually find these laws specific laws on ownership of the record and the information, and then the state hospital licensing laws. And notice I'm saying hospital here. Some states address all health information. Again, in the state of Alabama, the only laws on the books as far as medical records go are to deal with hospital records. I say that there are some laws in regard to nursing home records and things like that. But as far as ownership of the medical record, that is addressed in the state hospital licensing laws. Now, typical regulation provides that medical records are the property of the hospital and shall not be removed from its premises except for court purposes. Now, when we say property, what we mean is the record itself, whether it's the paper it's kept on, in the binder that it's kept in, or the computer hardware where it's stored. So the actual physical record is the property of the hospital. And most laws will say that it should not be removed from the hospital except for court purposes. So if you've got a subpoena or a court order and you had to show up in court with that record, then you could remove it from the premises. Now, just an example. Louisiana law states that medical records are the property and business records of the healthcare provider, and that a patient has a right to obtain a copy of his or her record. So if they're the property of the hospital, the paper or the computer disk where the records are stored, the patient still has a right to copy that information. Doesn't have a right to come in and demand the original, because that's the property of the facility. And you'll see a lot of laws that are stated like this. I want to point out there is no constitutional right to access one's health information. That's what I was talking about a minute ago. It's state by state, and but nowhere in the Constitution does it say that we as Americans have a right to our health information. But again, now that HIPAA is in effect, HIPAA, not the Constitution of the United States, gives the patient the right to access his or her health information. Now let's look at federal law. I just mentioned the Constitution. Now the constitutional right to privacy, not necessarily if we can access, but who has access or what our rights are to privacy, provides just a limited protection in regard to health information. There's also an act on the federal level that was enacted in 1974. It's called the Privacy Act of 1974. And what the Privacy Act does is it gives private citizens some control over the information that's collected on them by the federal government. It limits the information the federal government can keep on private citizens, and it limits the uses of the information. So, in other words, it keeps private information that's gathered on citizens that's kept by the federal government. And we have all kinds of records. It doesn't say specifically health records or anything. We have all types of records that are kept on us, on each individual citizen by the federal government. What about our IRS records? Those types of things. So we all have records that are kept by the federal government, and we have protection to say that they will remain private. Of course, there are exceptions to the rules, but as a general tenet, the Privacy Act protects us to say that the information that's kept by the government is limited, and also that it should be kept confidential. Another thing that Privacy Act did is allow individuals to gain access to the records that are kept on them by the federal government and to copy the information. Again, there are exceptions to the rule, but as a general rule, the Privacy Act of 1974 gives each of us as citizens of the United States a right to copies of information that's kept on us by the federal government. Now, as I said, there are exceptions. So the Privacy Act does allow agencies to disclose information about an individual without the patient or persons. Now, even the word patient, this has really nothing to do with patients. It has to do with individual citizens. So without person's consent in certain circumstances. Now, this act or law only applies to federal agencies. Hospitals funded by federal government are bound by this act not to release patient information without consent. And so, normally the Privacy Act doesn't affect us in the healthcare field, but I've had it several times. We're going to talk about the Freedom of Information Act too, but I've had individuals come in to me in health information saying that under the Privacy Act or the Freedom of Information Act that they had a right to access their health information. Well, this was back before HIPAA, and it really didn't. So you would have to explain that those are federal acts and they're to do with federal government records, and that if you worked at an institution that had nothing to do with the federal government, that act really doesn't cover you, except as a private citizen, where you can have access to your information kept by the government, and it should be protected. Now, I just mentioned the Freedom of Information Act. It gives the public access to information on the operations and decisions of federal administrative agencies. Now, to get these two separate in your mind, the Privacy Act is about private information kept on individuals by the government. Where the Freedom of Information Act gives us as citizens access to information that's kept on the operations and the decisions of the federal government or federal administrative agencies. Now, the only way that that Freedom of Information Act would apply to anybody in health information or anybody who protects health information is if you work in a federal government hospital such as a VA hospital. Now, it requires federal agencies to make certain information available for public inspection and copying. And again, if anybody were to come into you and say something about the Freedom of Information Act, and that really, unless you work for the federal government, that has nothing to do on a private basis about health information that's kept on patients. But again, and I know I sound like a broken record, now we have HIPAA, and HIPAA is a federal act that gives patients access, but not the Freedom of Information Act. That was federal law. Let's look at state law. Now, the statutory provisions of written laws concerning health information are often found throughout the state's code. The code is just a recording of those written laws. Each state has a code. There's the Code of Federal Regulations that we talked about. So that's just think of it as the document that holds those written laws or statutes. And within the state, there may be medical record acts within a state. There may be hospital licensing acts. That's where you find those hospital licensing laws or regulations. HMO acts. There may be specific statutes dealing with specific situations such as confidentiality of patients' records where the patient is HIV positive or has AIDS. And so, again, state law, always remember, it may change when you cross the state line. Just because you work in Alabama and you know all the laws pertaining to confidentiality of health information, you may not know all of them once you go to Tennessee or Georgia or across the country. And when I say, probably for the 10th time in 5 minutes, that HIPAA now covers the privacy of records, I say this right now, I put it on the slide so that I could mention that if the state law and there's a federal law, which HIPAA is, if they are in conflict, then HIPAA or the federal regulation or law will supersede. Meaning, if the state law says one thing and it is not along the lines of what HIPAA or any federal law says, then you go by the federal law. You go by the higher law, basically. Now, Medicare conditions of participation, again, for any facility that participates in this program and receives funds from Medicare for treatment given to the Medicare beneficiaries, then they have to go by the Medicare conditions of participation. And within those conditions of participation, just like there's regulations regarding what has to be on a record, documentation requirements, and all types of things like that, there's also requirements that institutions participating in the Medicare and Medicaid programs are to keep medical records confidential. It's stated in the Medicare conditions of participation. And these conditions of participation apply to hospitals, nursing homes, home health agencies, substance abuse agencies, hospices, those organizations that do participate in the Medicare program. Now, where the Medicare conditions of participation are for those who participate in the Medicare program or receive funds, HIPAA applies to everybody. It doesn't matter if you do or don't receive funding from Medicare. Now, accreditation organizations, they all have standards in regard to confidentiality of medical records or health information. And so, another thing you need to be aware of is that you need to know the HIPAA regulations. You need to know what the conditions of participation say about confidentiality. You need to know what the state laws are. And you need to also, if you work at an accredited facility or organization, you have to know what the standards as far as that accrediting agency are. Even though they're not law, they're binding if you have accreditation. So if it's Joint Commission accredited, you want to look in the Joint Commission standards to find out the standards that apply to confidentiality. And you find those standards in the IM, or the the Management of Information section. And you'll go over Joint Commission standards, and we go over them in every class basically because they pretty much affect every aspect of health information. But in your QI class, you'll cover them in more detail and actually get to look at the Joint Commission standards and things like that. But the information management, the IM or Management of Information section will have the standards dealing with confidentiality of medical records. Now let's look at uses and disclosures of medical record information. We say it's confidential. It means that the access to the information, that medical information, must be limited. And it is usually limited to the patient or the patient's authorized representative. And as authorized representative, I mean, it could be a guardian, it could be a parent, if it's not the patient. The attending physician, and then other staff members with a legitimate interest in the record as it relates to patient care. So not just curiosity as far as interest, those that with a legitimate need to know. And that goes along with that treatment, payment, and operation. There are things that are done in a hospital or healthcare facility that don't have anything to do with direct patient care, but it is related to the treatment, payment, and operation of the facility as well as treatment of the patient. And so those staff members would need to have access to the patient's medical records or protected health information. And usually a parent has to authorize disclosure of a minor's medical record. However, in some situations, the minor will be able to authorize the disclosure of the medical record information, him or herself. So it just depends on the circumstances. And there are circumstances in which a minor can consent to treatment if it is specified by law, let me say it that way. And so even though they're still a minor, they have not reached the age of majority, whether that's 19 or 18. Again, that's state law as to when someone is an adult. But if a minor consents to the treatment, the minor should consent to the release of information. So in other words, if we treat a minor at our facility and the minor consents to that treatment, can consent to it by law, then you would go then and ask parents to sign for the release of information if that information had to be sent somewhere else. So they go hand in hand. If the minor consents to the treatment, the minor consents to the release of information. We'll get into this a lot more. In the state of Alabama, 14 years of age, a minor can consent to any medical treatment. They're not a minor or major. They haven't reached major majority. They're not an adult. But the state law in Alabama says at 14 years of age that minor can consent to any medical treatment. Now, access on behalf of the patient. So not patient access, but on behalf of the patient. The patient or the patient's representative has the right to authorize disclosure of confidential patient information to others, to third parties. Now, the person who is seeking access to the information must typically make a written request and also pay a fee before the records become available. And this is with patient authorization. If the patient can authorize someone else to see his or her record or to be sent a copy of his or her record. This could be a lawyer, it could be for Social Security determination, it could be for disability determination, it could be for all kinds of reasons that the patient needs records sent somewhere else. It could be for continuing health care at another facility with another physician. There's all types of reasons why a patient will give consent. I'm using those words interchangeably, and I should not do that anymore. Give authorization, not consent. Now, some states allow patients to review their medical records while they're in the hospital. Now, HIPAA doesn't say that, but remember there are state laws. And if HIPAA doesn't say anything, but there's a state law in the book that's more strict, and you go by the state law. But if HIPAA specifically said patients cannot view their record until they're discharged from the hospital, then we would go by what HIPAA said. But some states will say that patients not only have a right to access their records, but they can look at it while they're in the hospital. Now, other states have laws on the books that restricts the right of access until after discharge from the hospital. So as the record's being made, the patients don't have access to it, but they do have access to it upon discharge. And remember what HIPAA says as far as you have to answer a request for patient access to the record within 30 days. And so normally the patient might be in the hospital for 30 days. And so it would be after discharge when you would give them access to the record. And the reason for that is that, as you know by now, when a patient's in the hospital, that record's not complete. People are working on it all the time. And usually within 30 days, that's the cutoff line for a record to be completed, because after that it would be deleted. And so some state laws actually take that into account and say that only after discharge the patient have access to the medical record, and patients have access to their medical record. Now, some statutes, some state laws allow for a healthcare provider or a hospital to refuse a request for access to psychiatric information. So there'll be a differentiation there. So with all medical information, the patient has access to it, except you can refuse access to psychiatric records. Now, HIPAA, if you remember, addresses this, but it addresses it in regard to psychotherapy notes made by a therapist. Now, another thing that some state laws and regulations will prescribe is a time limit for response to a request for access to medical record information. New York has a law on the books that says within 10 days. California has one that says within 15 days. Illinois says 60 days. What does HIPAA say? Remember back, HIPAA, as I mentioned about 30 seconds ago, says 30 days. So, if you look at these state laws, and if New York has 10 days and HIPAA says 30, they're going to have to do it within 10 days because there is a more stringent state law on the book. It doesn't disregard what HIPAA says. it's more strict. And so in New York, if you get a request for patient information, you have to answer it within 10 days. California, 15. That's okay, but look at the Illinois law, which I'm sure was on the books before HIPAA was enacted. So it says 60 days, HIPAA says 30. The federal law supersedes, and so it's 30 days. No matter what the law is on the books of the state of Illinois, so they have 60 days. They don't have 60 days now, they have 30 days. Now, copies of health care records should never be disclosed to any third party in the absence of an authorization signed by the patient. And usually, when you see never, well, is that true? Of course, there's exceptions by law that we have to release information without patient authorization. But the general rule, don't ever give out copies for patient information without a signed authorization by the patient or the patient's legal representative. Now, HIPAA is very, very specific as to what has to go on that authorization. You have a copy of it in the presentation. I gave you a handout of a sample release of information authorization. And it had all the different components that are required by HIPAA. And again, that was in the section where we actually went over HIPAA, and that was all. Now, in your textbook, in this particular chapter that we're talking about now, there is a list, a bulleted list of everything that has to be on an authorization according to HIPAA. So as I gave you an example of an actual authorization in your handouts, the book actually lists what has to be on there. There has to be a specific description of the information to be used. There has to be a statement about ability or inability of the covered entity to condition treatment, payment, enrollment, or anything the patient, not based on whether the patient signs the authorization. A statement notifying the patient of the potential that if PHI is disclosed or released, that the party who's receiving it may re-release it without authorization, that there's a chance of that it can be revoked, that there's an expiration date. All of those things are listed. So every authorization now for release of information needs to have at a minimum those particular items. Now, another thing, before a healthcare organization releases information to a third party, it needs to verify the identity. Now, along with this particular chapter, I've also given you a demonstration on release of information. For example, if you receive a written request or a written authorization, and maybe somebody comes in to the department, hands it to you, and say, I have authorization to these healthcare records, and the patient signed it and everything, then we want to verify the identity. And verifying the identity could be asking for a picture ID and making a copy of that ID. If we're doing it through the mail and we're sending it to, for example, the patient has had an authorization, a valid authorization to send information to an insurance company, and we send it via the mail to that insurance company, it should only be opened by the addressee. And so it doesn't mean that we have to verify the identity. Of course, we would never send anything if we thought that it was false, that if somebody says send it for this address and it's not really an insurance company, then we would not send it. But that's what I'm talking about verifying the identity of third parties that are requesting information, even when they have an authorization signed by the patient. Now, another thing we have to take into account are facility directories. And you may not be used to this terminology, but HIPAA is very specific about facility directories. Directories can include the patient's name, location in the facility, condition, religious affiliation. It's that information that if you have a friend or family member in the hospital, if you call the main hospital number and you say, I'd like to have the room number for John Smith, and they would give it to you. So could you give me his condition? Well, is it good? Is it fair? Is it critical? Those types of things. And so that's what's considered a facility directory. Now, the privacy rule of HIPAA says that's okay, that healthcare providers can use that protected health information to create these directories. But they have to inform the patient, and the patient has to have the opportunity to opt out and say, no, I don't want my name on that. I don't want anybody to be able to call in and find out that I'm here or what my condition is, or I don't want the church to be able to find out what my religious affiliation is. It's my business. And so that's what they mean by opting out of the facility directory. Now, records of minors. I've already mentioned this briefly, but generally, the healthcare organization may disclose the medical record of a minor patient with authorization from one of the parents of an unemancipated minor. That's one that's still under parental control. Basically, anyone that has not reached the age of majority. And we said there were exceptions to that. That if the minor could legally consent to a particular type of treatment and does do that, then the minor needs to consent to the release of information. But in general, if the parents of a minor who is unemancipated authorize the release, then that's acceptable. Now, the guardian has been appointed to act in the child's behalf. Only the guardian may access the minor's health records or authorize the release to a third party. A minor patient, again, may authorize release of medical information to third parties if the information was obtained during the course of providing health care services to which the minor lawfully could consent under the law. So that's just restating what I said a minute ago. In general, the parents need to consent, but if the minor originally gave consent for treatment, the minor gives consent for the release of information in regard to that treatment. But remember what a mature minor is versus an emancipated minor. An emancipated minor is one that has basically divorced his or her parents and gone to court to become an adult before that age of majority. But a mature minor is one that can consent to medical care under the law in certain circumstances. And so, in Alabama, if anybody at 14 or ages or older can consent to treatment, but there are even lower age limits on a minor in Alabama being able to consent for treatment for venereal disease or pregnancy or something like that. And we're going to go over that in detail as far as the Alabama laws later on. But an emancipated minor is no longer under control of the parents, and that's a court proceeding. Think of it as a divorce, where a mature minor is only mature for certain circumstances. So a mature minor can't go receive treatment for drug and alcohol treatment. And it's mature even though that person's still a minor. In that particular case, for treatment of drug and alcohol abuse or dependence, they're mature under the law and can consent. So that's the difference in that terminology. Mature minor, an emancipated minor, and an unemancipated minor. Now access for treatment, payment, and operations. HIPAA allows for this. Remember, we've gone over this with HIPAA. So within the facility for treatment, payment, and operations, we don't have to have a special consent from the patient, although we do have to give them a privacy notice and tell them how their health information, their PHI, may be used for treatment, payment, and operations. I give you an example of a consent form for TPO. Initially, right when HIPAA came about, it was required that the hospitals or the public entities have this done. That is no longer a requirement, but they do have to inform via that privacy notice in regard to how that information may be used for treatment, payment, and operations. Now, mental health records. Now, some states have specific rules or specific laws in regard to psychiatric records that are different from standard medical records. And usually it's in addition. Like you have your laws for your standard medical records, and then there's additional rules and regulations for mental health records or psychiatric records. Now, in the past, mental health patients could be denied access to their medical records even where non-mental health patients in the same jurisdiction have the right to have access to their records. And then some states would be right the opposite and have a law on the books that says that stated that mental health patients did have a legal right to access their medical records. If a state doesn't have a law, and that's sometimes the case, I keep talking about states having laws and they'll differ from state to state. Just as I said initially when we started talking about access to the medical record information or health information, that in some cases Alabama doesn't even have a law on the books. And so when I'm talking about patient access, there is no law. And so if there's no law in the state governing health records, then the record would fall under the same rules as standard records. And so HIPAA covers psychotherapy notes. And so, again, since all covered entities are impacted and have to follow HIPAA, remember it's just those psychotherapy notes. It's not a whole mental health record itself. It is specifically psychotherapy notes. Now, alcohol and drug abuse patient records. This is we talk about this in several classes, but with the alcohol and drug abuse patient records, until HIPAA came along, this was one of the very few instances in which the federal government actually had any rules on the books or laws on the books regarding medical records. They left it up to the states. But under the Public Health Service Act, it pertains specifically to alcohol and drug abuse patient records. So if you work in one of those facilities or worked in one of those facilities even before HIPAA, then you are affected by this and you do treat these records differently. And now what that alcohol and drug abuse patient what the Public Health Service Act said about the alcohol and drug abuse patient records is that the records, any records of the identity, diagnosis, prognosis, or treatment of any patient maintained in connection with the performance of any educational, training, treatment, rehab, or research program concerning drug or alcohol abuse may not be disclosed except for certain purposes and under certain circumstances. And so these records are protected by a particular federal law. We go over this in HIT 153 in your healthcare delivery systems class. Now, to go into a little bit more detail with this particular act is that virtually every alcohol and drug treatment facility is covered because it talks about federally assisted, and most every treatment program in the country receives Medicare funds. And so, or that's how they're paid. In part, if they have a Medicare patient, of course the federal government will pay the bill. And so, basically every facility is going to be covered. And when they say program, it refers to an individual partnership, corporation, governmental agency, or other legal entity that holds itself out as providing alcohol and drug abuse diagnosis, treatment, or referral for treatment. Now, I want to point out something here because I remember when I was in the field, this caused some confusion initially, and you will find at different facilities the way this is interpreted is different. What they're talking about as a program is actually a place that provides treatment. I think I've told y'all many times I used to work at an alcohol and drug rehab hospital. Provided those services and mental health services. Now, that definitely was a program because that's what they did. They provided services to people with alcohol and drug abuse problems. But I also worked at other hospitals that didn't have alcohol and drug rehab, even have units, but they were actually, they have a patient record that on the discharge diagnosis, the doctor would write alcohol dependency or some type of drug dependency or abuse. But that's not why they were in the hospital. They weren't attending a program. The hospital didn't have a program, but it was listed as a diagnosis on the chart. And this somehow got misinterpreted because there are other rules and regulations as far as having to have a court order and not a subpoena for a chart with alcohol and drug rehab patients or treatment patients. And so I worked for one hospital that felt that they fell up under that, and they really didn't because they weren't an alcohol treatment program or a drug treatment program. And some patients would have diagnoses on their charts, and we'd get a subpoena for the chart, and then we'd have to contact the individual that had the subpoena issued and say, no, we're going to have a court order, and that wasn't right. It's only for programs that actually treat patients with alcohol and drug abuse problems. Now, for a general hospital to qualify as a program, it has to have an identified unit that provides alcohol and drug abuse services. So you may work at a facility that's what they did. That's the whole thing. I worked at a hospital. That's what that hospital did. That in addition to psychiatric care. But a general hospital can have a particular unit that is an alcohol and drug rehab unit within the hospital. That is a program. But only people who were on that unit and receiving treatment would fall into the category as being protected by this federal act. Now, any alcohol or drug abuse treatment program under this legislation may not disclose any information, whether it's recorded or not, that would identify a patient as an alcohol or drug user either directly or indirectly. And so what this means is that, for example, when it says directly or indirectly, think about it. If we were just talking about those facility directories. If somebody calls an alcohol and drug rehab hospital and says, could you give me so-and-so's room number? Oh, sure. Well, we're identifying that individual if we give that information out as an alcohol or drug user. And so that is prohibited. So you can't even, but you also, they say you can't do it implicitly or you can't comply if that's the case. And what that means is that if you had a drug unit or alcohol unit in the hospital and you gave that information on all other patients, that when somebody calls and said, oh, well, they're on a unit where I can't give you that information, that is indirectly or implicitly giving that information out. So we have to be very, very careful. Now, one thing, even though the laws are very strict on releasing this information, doesn't mean we can't give it out at all. Of course we give it out if we have patient authorization. That's the main thing. We have patient consent. There are other circumstances where we can release information, but of course we can release it if we have the patient's authorization to do that. Now, the law is very specific to say the consent has to be in writing, it has to be signed by the patient, it has to describe exactly what's going to be released and the purpose of the disclosure. So if you look at this is even less than what HIPAA now says. You know, HIPAA has a lot more items that have to be on an authorization. And but that's what this federal law says strictly about the alcohol and drug rehab records. So even though this is what that law says, since HIPAA came into being, we're going to have more on that authorization because of HIPAA. HIPAA is more strict. Again, minors can consent to release of their information for alcohol and drug rehab treatment if they consented to treatment. Now, I mentioned this back in HIT 153, but another thing about this federal law, that information released has to be accompanied by what's called a prohibition of redisclosure. You just look at the term. It prohibits re-releasing records. That's all that means. A prohibition of redisclosure is a statement that prohibits the person who is receiving information to turn around and give it to somebody else. The federal law is very specific about the prohibition of redisclosure, and it will say exactly the words. You don't paraphrase, you don't change it and say, well, I think this sounds better. It has to be in these exact words. And I've given you a copy here. I've given you a copy in the past that this prohibition of redisclosure is sometimes it's just printed on a sheet, and if we make copies of a record for a legitimate request that we have authorization for, we will put this on the front of the record so that whoever gets that record, that's the first thing they see. Other things, we can have it on a stamp and actually stamp it on the record, or we could have it on a, when I say a stamp, I'm talking about an ink stamp. We can also have this as a peel-off stamp that we can put on the first page of the record when somebody's receiving it. But I found that, when I worked in this environment, we always, and this is just common practice in any hospital or healthcare facility, when you receive an authorization for release of information, and it's legitimate, it's valid, you copy the record, you put a copy of the authorization that you got on the front of the chart. Staple it to the front of the chart. It will be the first page that somebody sees when they receive the record. So what we did is we automatically had it printed on the bottom of our authorization. And so when we made the copy of the authorization on the chart, then that was copied with it. And so there's just different ways that the federal law states that you have to have the statement with all alcohol and drug records that you disclose. And again, it's part of the Code of Federal Regulations, Title 42, Part 2. That's where you can find it written. Now, disclosure without consent or without patient authorization is permitted under limited circumstances, such as a medical emergency that poses an immediate threat to the health of the patient. Now, if this is done, certain information has to be entered in the patient's record. The name of the person to whom the disclosure was made, name of the individual making the disclosure, the date and time of the disclosure, and the nature of the emergency. If this happens and we don't have an authorization, this would only be to another healthcare provider that we would do this. That's the only way it could be a life and death situation. It's not an emergency if someone forgets to do their paperwork or gets a letter from Social Security or something that says, we have to have this or we can bill last Thursday. That's not a medical emergency. It is a medical emergency if we get a call and that patient's in another hospital or in an emergency room and the healthcare provider on the other line says, this is a medical emergency. Now, we talk about this in other situations, and we'll talk about it when we go through all that law manual. If we do this, and we may do this in this circumstance, the federal law says we can, but if we could do this if it wasn't an alcohol and drug rehab patient, if it was a medical emergency and we couldn't get assigned authorization, is that if we're going to do this, we're going to call back and verify who's on the other end of the line. We don't just say, oh, well, hold on a minute, yeah, they're from so-and-so hospital. We verify who that person is, and then we want to write in the record what we did, why we did it, who we gave the information to, when we did it, and what was the nature of that medical emergency. And so that way, if anything were to ever come up, if you look at it, nothing was done with malice or with or intentionally to hurt a patient. It was with the patient's best interest that we would release that information without an authorization if it is a life and death situation. Or, I say life and death, if it is an immediate threat to the health of the patient. Now, also, a way that we can release information from an alcohol and drug rehab patient without their consent, his or her consent, is if we get a court order. Not a subpoena, but a court order. So if we get a subpoena, we have to say we can't release that information. But here's another situation in which you're just kind of dancing around the issue, because remember when I said the law says you can't even indirectly imply that a patient is a patient with authorization or if it's required by law. And so if I would receive a subpoena for a patient's record at the Alcohol and Drug Rehab Hospital, I could not honor it, but I couldn't call the attorney that had the subpoena issue and say, I can't answer the subpoena because I have to have a court order because this is a drug and alcohol patient. I couldn't say that. And so what I would have to say is, if we have records on this person, we will release them with a court order. And they would argue saying, can't you just tell me? And if you don't have records, then I'm not going to go get a court order for records that you don't have. No. If I have records, I cannot acknowledge that or say I do or I don't. But if I do, I can't honor the subpoena, and you need to get a court order in order for me to get these records. If we do have records on patients, so you have to be kind of talented in the way you phrase things. If the subpoena, if you get a subpoena, you do not honor it. You do not send the records, we'll just accept it. Now, disclosure for medical research. Now, this used to be covered in this particular chapter in the book. It's not now. You have an old chapter at the end of the book that talks about medical research. I'm going to touch on this very briefly and just let you know that this is in the last chapter of the textbook. But as far as release of information or access to medical information, medical research, there are many medical research projects that only use patient records. And this is done to track the results of specific types of therapy, areas of the population, and instances of certain illnesses for statistical purposes. And so if this is done and that information is de-identified and nobody can tell, it's not really interested in that particular person, then that's not a problem. But if the hospital is conducting experimental research, there's two different kinds. There's research when you look back on what was done. One patient had one treatment versus one had another, or a particular area that patients tend to have certain diseases for. You're looking at those types of things, or that the researchers are, as opposed to if a hospital is actually conducting experiments on human beings. There has to be, in that case, an institutional review board, what's called an IRB, to evaluate and approve the research. And so it's different to have an IRB. If there is one, they may approve all research, such as that's just done on record. But if a hospital doesn't do experimental research on people, they won't have an IRB. And so, if that's the case, if it's just paper research, this is usually approved to the medical record committee if there is no IRB. And there probably won't be if they don't do the experimental research. So just to introduce you to that particular term, the institutional review board that reviews requests for research. Now, record duplication fees. Healthcare providers can charge for duplication of records, what's called copying fees. Some state laws will say what we can charge. Others don't. The others will say, okay, you can charge, but it has to be reasonable. And that usually makes everybody in the area is charging the same thing. It may be something like $5 for the first 5 pages, and then 10 cents a page after, or 50 cents a page after. And other states will be very specific as to what you can charge, so it just depends on the state. HIPAA says, even though HIPAA says we have to give patients access to their records, they say that we can charge for making copies of records. And so they don't say how much, but then if there's a state law that does say how much, then we would go by that. Now let's briefly look at record security. And this is something that, in the new edition to the book, it's not referred to, but I want it, and it is referred to. There's a lot of things about HIPAA security rule, but this in particular, when I'm talking about access to records, I wanted to bring this to your attention. Sometimes access doesn't mean that we're making copies. Sometimes access means that people come in to our department and actually view a record. And traditionally, it's been a paper record. And so we have to have certain safeguards to make sure that our records are secure, that they're not being altered or stolen or damaged in any way. And that's what we're talking about record security. It goes a lot further than that when we're talking about electronic health records, when things are kept on the computer. There are other security issues there, such as, viruses and worms and computer hardware malfunctions and those types of things. But let's look at record security from a paper record standpoint. If a patient and or the patient's representative asks to see a record and it's been authorized, then they can sit down with the record, but there's always a chance that they can change it, try to destroy parts of it. It's very easy to remove a page off the medical record. Just kind of jerk it real fast and it comes off the palm. And so, especially if there's a lawsuit pending. And normally a patient wouldn't try to do anything like this, and patient's representative may be the patient's lawyer. And so, to guard against that happening, or to protect against something that I'm referring to as abuse of the record. And what I mean by abuse, I don't mean throwing it up against the wall. I'm talking about those alterations or damage to the record, or stealing pages out of the record. Basically, that's what I'm talking about when I say abuse. To protect the medical record from abuse, they need to be stored in secure, restricted areas. So you don't leave the department open and let people who shouldn't have access to the department come in. Records should be in restricted areas on the units and in the health information department. Wherever the record is, it needs to be in a restricted area. And before anybody's going to sit down and look at that record, you need to examine it before it's reviewed by the patient or the representative. Sometimes that means going through it and actually numbering the pages. You need to know what's on that record. Never remove an original record from the premises except when required by law, because what if it was lost? What if something happened to the record? And so that would be followed in that abuse category. So instead of removing the original, we would take a copy if we had to take the information somewhere. But unless it's required by law, we should not ever be leaving a facility with a paper medical record. And the B, if the patient or the patient representative is going to come in to look at a record, you don't hand it to them and say, here, let's see. You stay there with them and watch every move. Never should they be left alone with a record. And so that means somebody sitting there right by their side watching everything they're doing. That way they cannot take out a pen and change the information. They cannot take off pages of the record or destroy pages of the record in any way. And so that's the big one. Never leave anybody alone with someone that's viewing the record. Now the last thing I want to talk about briefly is QIO record keeping. And with QIO, Quality Improvement Organizations, they used to be called QROs. Now they're QIOs. They are organizations that oversee the Medicare reimbursement program, and each state has a different QIO. And what it is, the QIOs are not part of the federal government, but they're contracted, they're organizations or companies that are contracted by the government to oversee the reimbursement, to make sure that the reimbursement is proper and that the Medicare patients are actually receiving quality care and that the government is not reimbursing too little or too much for the care given. And so the QIO will request, many times they used to come in and ask to see just to see the records. They'd show up at the hospital and they would schedule visits and you had to pull the records and they would look at it. They don't do that anymore. Now they request copies of all the records. And so, I say all of them. They will send a list of records that they want copies of, Medicare patient records. And so they request these medical records from hospitals. Now, under federal law, they have, since they're contracting with the federal government, they can have copies of these records, and they maintain copies of these records for them to review. They review the quality of the care given, the coding, all types of things like that. But while they have these copies of records, they're also required by federal law to keep these records confidential. So just because it passes to them, they can't redisclose them. They have to keep them secure. They cannot let anybody have unauthorized access to copies of records that they keep. Now, I've been down several times to AQAP or AQAP, AQAF, Alabama Quality Assurance Foundation in Birmingham. They're the state of Alabama's QIO, Quality Improvement Organization. And their records, the thing that always struck me is once they get copies of records, they'll put them in a folder just like we would at the hospital, but their letters on there, where we would have a color code and everything, I would call theirs generic records, because they would put numbers on the records so that they could find them when they were filed, but theirs were always in black and white, and it always looked funny to see. They basically had this big medical record department, basically, that kept copies of patient records, but I always thought they looked very generic. They may do things differently now, but they were always, their letters were in black and white. So, again, they cannot release or re-release records to third parties. Once these records go to the QIOs, that's where they stay until they're destroyed. They cannot re-release the records. So that's an overview, a pretty lengthy overview of access to health information. Again, our access is granted through state and federal laws, rules and regulations, who can have access, who can't, and what we have to do in order to actually give someone access to health information.